everyone. I'd like to start by welcoming you all to the first virtual meeting of the Health and Wellbeing Board. Before I move on to the agenda, I'd particularly like to introduce new members attending today for the first time. We've got Gary Jevon from Health Watch, Maddie Sutcliffe from Nova, and Lee Miller, District Commander, West Yorkshire Fire and Rescue. So welcome to you all. Moving on to the agenda, item 1 of the agenda is apologies for absence. Fran, have you got the apologies?
I have. We've got apologies from Councillor Collins and also Superintendent Mark McManus, but I believe Vicky White was attending, but I haven't seen her on the line. Oh, she is. She's on the line. So we've got Vicky White. Yeah.
That's great, thank you. And I believe that Tom Stannard may be a little bit late if he's not already here. Yeah. And Beate will be about 30 minutes late. If we can move on to item 2, the minutes of the meeting, the last meeting, can be found on pages 1 to 8. Can I ask that the minutes be moved as a correct record?
Yes, happy to support Councillor Hemstall.
Happy to support, thank you.
Thank you. I've got a few matters arising, so I'll go through them first and then I'll invite any other comments from the minutes if that's okay. So we can go to page 2 of the minutes, minute 58, the Health and Wellbeing Board Action Log. This is an unusual meeting today in the current circumstances. So the usual planned format of items and forward plan have been set aside for this meeting. But I just want to assure everyone that the next meeting will be in the usual format with a full update on the actions. And I can confirm that the amendments to the log have been made. Moving on to page 3, minute 59. At the last meeting, the board delegated the signing of the Memorandum of Understanding for the West Yorkshire and Harrogate Care Partnership to Joe. Just confirm, Joe, that this has happened.
Hi, Faith, it's Esther. I'm not sure whether Joe's got some difficulties with the call, but I can confirm that that's happened.
That's great. Thank you very much for that, Esther. Moving on to page 7, minute 64, just briefly in reference to the Step Up programme that is on the agenda today. And then to page 8, minute 65, there are a set of actions from the focus discussion from the last meeting, and I believe, Esther, you can provide an update on these?
I can, yes, Chair. The first action was about bringing a Healthy Schools programme to a future meeting of the board, and the agreement was that we would schedule this in as part of the children's priority discussion in the forward plan. The issues and lessons learned by the careers cabin to be shared with the Working Together executive and other partners. I think due to the circumstances changing and a number of official meetings being cancelled because of the response to COVID, that hasn't happened as yet, but that's planned next Wakefield Together executive. Also, the investigating the possibility of assisting the CAB with identifying the funding streams and increasing the number of volunteers. This is going to be discussed at the next Primary Care Network meeting. And the discussion around issues for the health and social care system and employment, that's on the agenda today. And then there was an issue about lack of support and advice for private sector housing tenants to be shared with Wakefield Together executive. Like the previous item, that will be once the Wakefield Together executive meet again, that'll be raised. And those are all the actions, Chair.
Thank you, Esther, that's great. Does anyone else have any questions or comments from the minutes, if they can just indicate in the message box? Okay, it doesn't look like we've got any further comments. So if I can move on to item 3, which is care announcements. As I've already said, this is an unusual meeting in the current circumstances, and I'd really like to thank everybody for getting it into your diary so quickly. There are a few things I'd like to say. First of all, I'd like to express my deep sadness for all those who passed away through COVID. and my sincere sympathies to the families. I'd also like to send my very best wishes to all those who have a challenging journey ahead of them in terms of their recovery. I have previously written to everyone some time ago, however, I'd still like to thank members in person for the hard work undertaken during the last 4 months. The work that has taken place in and out of the board over the last few years as a strategic board has meant that there's been a real strength of relationships and partnerships which have provided the foundation for working in this current context. I'm really not just proud of all the board members and the leadership that you all provide, but of all your staff who have worked so hard and without complaint, and of course the unsung heroes, the unpaid heroes who have worked to support some of our most vulnerable communities and people in this time. And I know some of these we're going to hear about today. I've also seen some incredible work that perhaps might not have happened so quickly in other times, and I know that as a system we will learn from and build on. I'd like to end my chair's announcements by saying that I've witnessed firsthand the absolutely incredible work that has been taking place across all our communities, including many individuals, community anchors, hubs and other groups, all of whom have worked together and forged new relationships and partnerships. And I extend a huge thank you to you all from all of us. So with that, if I can move on to agenda item 4, which is urgent items, and I have none. And then on to item 5, members' declaration of interest. If anyone finds that they have a declaration now, or as we go through the meeting, if they can please indicate. So that moves us on to item 6, which is public questions, and we have one question today which I will read out. I was then going to ask Susanna to respond to the question. I am aware that Susanna is having problems staying connected, so I hope Susanna is still on the line, but I will just start by reading the question. If a patient was unable to see a consultant at a hospital because of a pandemic and was therefore unable to get a prescription from the consultant, would the GP then allow GPs to prescribe the medication? So I'm just going to read that again. If a patient was unable to see a consultant at a hospital because of a pandemic and was therefore unable to get a prescription from the consultant, would the GP then allow GPs to prescribe the medication? So can I ask Susanna if she can respond to that, please?
Chair, it's Dr. Shepherd, Adam Shepherd here. Doesn't look like Susanna's here. Or
I'm quite happy
would you like me to answer the question?
I have got the response that Susanna was going to read out, if that's helpful for me to share that with the board.
You can do that, and I'm happy to comment afterwards if required. Okay, thank you.
That's great. Susanna provided a response which was that medicines that can only be prescribed in the hospital are known as red drugs. That means that prescribing can only happen in hospital for a number of reasons, and those reasons are either the drug is not widely available in community pharmacies, or the complexity of drug or dose regime, or the toxicity or danger of the drug, or a requisite need for a specialist to oversee treatment. It would have to be judged on a case-by-case basis, and as far as we're aware, there's no issues with access to medicines from the hospital at the moment. However, should this become a problem, let's look into it. And the Medicines Optimisation team at the CCG will be sure to raise it with Mid Yorkshire to see what resilience plans they have in place around this.
Thank you, Esther. Would you like to comment, Dr. Shepherd, or is that okay?
I think that reflects the view. Each prescriber is responsible for their own prescriptions. So as a GP, I am often asked to prescribe medications requested by consultants, and I'm happy to do that, particularly if there's shared care guidance or it's under our remit to prescribe as a primary care prescriber. The red drugs that Esther outlined are a little bit more of a difficult situation, but I think with the shared care guidance and support from consultants, individual cases will be looked upon. But certainly in primary care in this area, I've not found any issues with prescribing from hospital consultants. They can often do that remotely. And as I said, I'd be interested to hear if there are any issues, but I think everything seems to be working as it should be.
Thank you. Esther, can I just ask that we ensure that the member of the public also receives the response in writing, please?
Yes, of course, I will do.
Thank you. Okay, so that takes us on to agenda item 7, Wakefield Health and Care System learning from COVID-19 and planning for the future. Esther is going to make notes of any actions from the sections as we go through, and she'll also provide a summary at the end of each section just for your information. So as you can see, we have 4 sections, and we're going to start with the impact of COVID-19 on health and wellbeing priorities. Before I hand over to you, Jo, while it's important for us to focus much of the meeting on learning and next steps, I think it's also important to take a little time to reflect on our response to COVID as a system and what the impact of the virus has had on our health and wellbeing plan priorities. I know, Jo, you're leading on the item, but we'll be bringing in some other board members to give their reflections on the last 4 months. I'll also bring members in for questions and comments at the end of this item, if that's okay, so we're not interrupting Jo and the other board members. So if I can hand over to you, please, Jo.
Yeah, can everybody hear me?
Yes, thank you.
Oh, great. That's a relief. I was having trouble getting in, and I thought, oh, this is ridiculous. You know, it's one of those things that has worked when I've been on some of the council calls, and then I think, oh, it'll be fine, so I'll not go to the rehearsal bit trying to get in, and then it all went wrong. But hey, so I'm here, so thank you for that, Faith. Yeah, just as you've said, I thought I'd just offer some of my own personal reflections about the situation over the last 4 months. But we've also asked Martin Barclay from Mid Yorkshire, Sean Rayner from our Mental Health Trust, and Pat Keane to share their reflections as well in terms of the impact that COVID's had and some of the great work that we've done, but some of the challenges it leaves behind. So I suppose I'd start by, I think, just reiterating what you've said, Faith. Really, it's been quite a phenomenal response, really, and that we've had, and it's been a really challenging time for some of our patients, residents, and communities and staff. And I suppose it really represents the strength of the relationships that we have across the system, that we've responded so well to what has been an unprecedented level of anxiety. I think I've never known a time in my whole career, and I've been in health some years now, where it's just been overwhelming, the amount of challenge that we've all had to put up with, and the ambiguity around it all, and it's not just the impact that it's had on my working life, it's the impact it's had on my own personal life. So and I feel very fortunate that I haven't been in intensive care looking after those patients that unfortunately lost their lives, like you've said. It's been really, really sad, and that member of staff that's had to support that family that can't see their loved ones in the last hours of their life, and that must absolutely be a phenomenal impact on our staff as well. I haven't had to do that, and I feel fortunate not to have had to do that, but I do recognise the impact it's had. So whilst all that's been a challenge, I think we've learned lots. I think that we have responded very positively to this challenge. I think we've worked as a system, and I think we've not ever taken an opportunity to make every one of those challenges into something good that happened. I think we've had collective ownership across the whole system of the vision, problems and actions, and we've offered mutual aid and fast practical solutions, which has been done. I could never have dreamed that we would have been able to achieve some of this, but we certainly have. I think we had a very swift response from the council and from the system, and we joined up all our command and control systems, which have enabled us to be very resilient and keep communication open all the time. We've taken it was amazing how much the rapid adoption of the digital world started to play into our lives, and for years, you know, we've all been, the NHS particularly, has been behind the curve on the digital technology and how it could offer patient care in different ways, but we embraced that, and I think some of our primary care colleagues and colleagues in the hospital and in the community, etc., have really embraced that. I've seen some amazing work around discharge from hospital into communities, and some really innovative ways of how we've supported vulnerable people at home. I think the work that Anthony and Nelson has done around working with the voluntary and community sector, and I know we're going to hear about some of that from a carer's perspective, but has been absolutely amazing. I suppose I think what we've learned is that the pace of availability of testing, PPE for care homes and all those other things has really tested our ability to cope at times, and I think some of that being responsive in quite an agile way to those certain situations is something that I think is a lesson that we need to take into this next 12, 18 months, however long this situation continues. And the other thing that I think we've learned is that we need to be much more proactive in planning for scenarios that we are going to face undoubtedly over the next 12 to 18 months, however long. Because one of the things that I think we learned was that if we probably supported some of our care homes differently at the beginning, then we might have been in a better position. And that was a national thing, but it did give us some challenges, I think. I'm keen today that we focus on what we've learnt, how we can work more strategically as a board to understand the impact that this horrible disease has had on health inequalities, our vulnerable communities, and how we can think about the restart and stabilisation in that context, that we minimise the impact. But we do know that some of these things are going to be a significant challenge, and unfortunately there will be casualties around that. I think that, you know, the Health and Wellbeing Board and the 4 priorities, and if we can work against each of those areas today and think about what our next steps are strategically, I think will be really important. And I know we've got a number of presentations that are coming up later on the agenda to help us frame that strategic approach to what we might do for the future. So I'm going to pass over to Martin now, which I'm sure he'll be able to give you some reflections from his perspective. But it's been a really tough time for everybody. I think everybody says that, but it's been incredible, and for some more than others. But we did rise to the challenge. I think we've supported everybody. We saved as many lives as we could. We supported our staff the best way we can, and we brought our system together in a way that we would have all dreamed of. So I think that's a real credit to us all. So should I pass over to Martin now? I don't know whether he's on the call or not, because I missed the joining bit. So I'm hoping to hear.
I think Martin hasn't quite made it onto the call yet.
Okay, so should I keep John?
Hi, good afternoon. Can you hear me okay?
Yes, thank you, Sean.
Thank you, Chair. Good afternoon, everybody. My name is Sean Rayner. I'm a representative of South West Yorkshire Partnership NHS Trust, and I'm also Chair of the Wakefield Mental Health Alliance. I'll just briefly, if I may, Chair, just cover a few issues. I'll start first with a real life experience of a service user who, under the care of our community learning disability team provided by our South West Yorkshire Partnership Trust, and how we worked in partnership to support this individual during the pandemic. I'll be very brief, but I'll give you the key points from the experience of the service user. So the service user, I'll call Sally as a pseudonym. She's age 56, and she was under the care of the Wakefield Community Learning Disability team. Sally lives with her sister and has a personal assistant carer who works for 35 hours a week to help support Sally. At the point of lockdown, at the start of the pandemic, Sally was referred to the community nursing team on coordination of physical health difficulties that she had. And Sally has been shielded and formed a support bubble during lockdown. Initially, Sally was doing well and was monitored via wellbeing checks from a physiotherapist and a respiratory care nurse. And Sally was monitored on the respiratory pathway and placed on the respiratory risk register for COVID-19. The nurse liaised with Sally's GP around her complex health medication and completion of a referral to the gastroenterology team at Mid Yorks. Initially, the GP agreed to refer Sally for PEG consideration. PEG is percutaneous and endoscopic gastrostomy, but then put this on hold as the gastroenterology team were unable to take emergency referrals. A couple of weeks later, Sally deteriorated physical health and she required antibiotics for a query chest infection. So there was a number of challenges that Sally was experiencing. And through the course of her care, the nurse who were liaising with Sally were able to work with the complex care team at Mid Yorks to see if they could ensure that her gastroenterology referral was expedited. And that happened, and working in partnership with the GP, who provided some really excellent care and support, and the community team for learning disabilities and Mid Yorks, and also her social care input, Sally was able to be supported through a very difficult time, and assistant and personal assistant were really supportive obviously as well. So the outcomes for Sally during this period were that she was obviously anxious because of all the challenges and not being able to access care in the usual way, but through working in partnership, organisations and individuals are able to support Sally's changing health needs, and Sally's a very vulnerable person obviously, and that positive joint working and communication were able to support Sally through this period and continue to do so. So that's just one experience that obviously is unique to Sally and her carers, but obviously many vulnerable people have experienced similar situations in terms of support needs. So the final thing I'd say, Chair, is in my capacity as Chair of the Wakefield Health Alliance, which is an alliance of providers of mental health care plus the CCG, the Council, and other partners. We've continued to meet during the pandemic period. We've had weekly alliance meetings like this, and during that period we've had oversight of several initiatives that have been put in place to try and support the public, notably at a West Yorkshire level, a 24/7 mental health support line, a West Yorkshire grief and loss support service. We've started the development of a Wakefield mental health safe space. We've worked in partnership with Nova to implement a small grant scheme which has supported many voluntary sector organisations, and that was published very quickly just after the start of the pandemic. We've been very fortunate in having Gary Jevon from Healthwatch join us on this call today, joining our weekly meetings. So we've been able to see the public opinion that Gary's been able to secure through the Healthwatch survey, which has helped us adjust our approach as we move forward, and we will continue to do that. And we've also worked with wider community partners such as Sisters Advice and community hubs to ensure that our support for people with anxiety, depression, other mental ill health symptoms is available when they need it in the right time and the right place. So that shares just a very brief summary of the work that of partners in this support have been operating through this period. Thank you.
Thank you, Sean. Do we have Martin now on the call?
I'm here now. Yep.
All right, Martin.
Sorry, I missed that, Chairman.
Yeah, I was just checking you were on the call, Martin, so I'll hand over to you if that's okay with you.
Yes, so the brief I got was, to share with the committee, some of the issues that we've been grappling with over the past few months. Is that correct?
Yes, Martin.
Yeah, thank you. You probably will know that it seems to us that the incidence of COVID-19 in West Yorkshire, that Wakefield was sort of in the front of that spread of COVID-19 into West Yorkshire, because in comparison with other acute trusts in West Yorkshire, ourselves, closely followed by Calderdale and Huddersfield Foundation Trust, had a high number of inpatients in the early days in March. And the numbers of such patients were doubling every 5 or 6 days. And we reached our peak on the 10th of April of 170 inpatients. We were expecting a further doubling in the following week. And we would have coped with that. But as luck would have it, or as good fortune would have it, the 170 was our peak. We did open extra capacity in intensive care, and indeed converted our theatre recovery unit and adjoining day case surgery ward into an intensive care facility, which we only needed to use for a few days. But within our intensive care facility, we did increase the number of ventilated beds. And we were lucky because earlier in the calendar year, we had bought quite a lot of new ventilators, and we had not disposed of the old ventilators. So it was very easy actually for us to double the T. But after a couple of weeks, there was increasing evidence about the effectiveness of non-invasive ventilation using high pressurized provision of oxygen with airtight masks that go around the patient's face, often using up to 60 litres of oxygen per minute, just to give you some idea of the volume of oxygen that this technique enabled patients to have. Whereas usually for patients on normal supply of oxygen at the bed, that rate is about 6 litres a minute. So just to put that contrast in. We had a steady decline of the number of inpatients, and having said that, for about 2 or 3 weeks, we did plateau at a level of 80 to 85 inpatients at any one time. But that number has steadily come down, and we now have in the region of 8 to 10 inpatients, with only one of those patients being on a ventilator, and only one of those patients being on this CPAP machine with the airtight mask to put high levels of oxygen into patients. The Staff absolutely, rallied round. There was good team working, people pulling together. So many thousands of our staff were working in different ways than they'd ever imagined doing. Some people working even in different hospitals than they were used to. The community staff kept going more or less as usual throughout this, but with a higher number of non-face-to-face contacts. So that's worked, I think, very well. We've had good feedback from GPs about the work the community nursing team have been doing throughout this whole period. We had to change the use of quite a few wards, and not just designating them between COVID wards and non-COVID wards, but absolutely rapidly changing patient pathways and admission pathways at the beginning or second or third week in March. And all of those, I think, have stood the test of time well. There is no doubt that for many of our nursing staff and medical staff, particularly those working with the sickest patients, it has had an impact on staff. I think it's been really, really hard for staff, as well as relatives, of course, not being able to visit their relatives, especially when they've been so sick and and passing away as well. Eventually, we did work out a way of enabling visitors to visit patients in intensive care if a patient was approaching their end of life. And in May, we established a palliative care ward as well, which I think really, really helped massively both the patients and relatives. So I think there's been, so we've adapted, both clinical practice and visiting arrangements and so on, as we have learnt more about living and working and helping patients with COVID. But nevertheless, the emotional impact on staff has been significant, and people will need time to regain resilience. I think it's important that there is a lot of time invested in allowing staff to bear testimony to their experiences. Often it seems important to many staff to be able to talk to people about what they have gone through and experienced. But part of that is also tinged with high levels of anxiety about the possibility of a second peak, and the thought of going through all of this again, I think, is also impacting on quite a few staff. The phase that we are now in is in a state of flux, I think, is the truth of the matter, as we move from, or have moved out really, of phase one of this COVID pandemic and gear up to do as much non-COVID related urgent clinical work as we can. And particularly, I think, to be able to make use of the next 4 or 5 months, before the late autumn, early winter arrives, with all of the communal garden viruses and so on. And given the fact that the early symptoms of COVID are so close to all of the other communal garden viruses, and the respiratory problems that people experience, or many of our citizens experience at the autumn and winter, I think, again, the pressure on beds and the absolute vital importance of treating people as though they do have COVID until proven otherwise, is going to, again, be pretty impactful on inpatient capacity. And during all of this, the absolutely central importance of infection prevention control measures, which are absolutely the heart of keeping patients safe, reducing patient-to-patient infection, reducing patient-to-staff infection, reducing staff-to-patient infection and staff-to-staff infection, because the prevalence of asymptomatic people with COVID, is not insignificant. So some trusts, I think, have tested samples, or about 800 of their staff. We weren't one of the ones that were asked to pilot this, and the level of asymptomatic staff that proved positive has varied between 2 and 5%. So they are quite high numbers, and as I say, there's a risk of staff to staff and staff to patient infection. And for that reason, about 3 or 4 weeks ago now, it became new guidance was issued by Public Health England about the importance of staff wearing masks, even when walking in the corridors of hospitals, not just in patient areas. As we move forward with getting as much non-COVID work done as possible, this in my career is definitely the most complicated program of work I've ever had to try and help and support with. Everybody wants to get going and do as much as humanly possible, but the IPC, the compliance with IPC, I've just literally come off a call about radiology diagnostic capacity, and certainly with MRI scans and CT scanners, everything has to be thoroughly cleaned down after each patient, staff changing PPE, and all of that absolutely slows down the number of patients that can receive their diagnostic examination in every half day and so on. So with the best will in the world, we are never going to get back to usual levels of activity during this time. And that is, of course, a real concern to everybody, not least of which patients who may have been waiting for an important diagnostic test and everything else for some time. There's also the constraints of staff absence. So our sickness rate has gone up, which isn't surprising, but we also have about 300 other staff who are shielding or self-isolating and other things at any one time. So that means about 10% of our workforce now are typically away from work at any one time. So they're the sort of constraints, and whilst in theory it sounds simple to get activity going back to where it was, these important constraints, which absolutely cannot be ignored, especially IPC, are slowing things down and impacting on the timeliness of services that we are providing to patients. So I hope by way of an overview that is helpful, and happy to take any questions if there are any.
We're just going to take questions, Martin, after Pat's spoken as well. So
okay. Of course, that's fine.
Yeah, I appreciate you a little bit late. So Joe sort of done information as I've Sean. So now we're just going to, is Pat on the call?
I am, Chair. Can you hear me?
I can, yes. Thank you, Pat.
Excellent. Thanks, Chair. Okay. My name's Pat Keane. I'm a director employed within Wakefield CCG. But for this call, I've been providing the leadership and coordination across Wakefield and the wider Mid-Yorkshire system on the tactical response to COVID-19. And I'm just going to spend a few minutes describing a bit about the process, but particularly what we've been doing in that space. Just a brief explanation of what that tactical response means. So basically, the focus has very much been around bringing together the health and social care system, and that's across Mid-Yorkshire. The reason being that Mid-Yorkshire Hospitals provides the majority of acute services across both Wakefield but also Kirklees. So it's been important for us to have a partnership relationship with Kirklees because of the way that patients are managed within the Mid-Yorkshire Hospital. Also, Mid-Yorkshire provide the community services, as Martin's mentioned, for Wakefield. So that really has been bringing together colleagues from Mid-Yorkshire with both CCGs, that's Wakefield and North Kirklees, with Locala, who provide community services for Kirklees, with colleagues from Swift, and obviously Sean's been on the call. Very importantly, hospices, public health colleagues to give us regular updates on information regarding activity. The local authority, and that's particularly in terms of social care provision. And the focus really has been to respond to three elements of the tactical response. So that's tackling COVID, living effectively with it, and moving past it. And those have been the three key focuses from a tactical perspective. I'll come back to sort of health and social care tactical response in a moment. I also led a multi-agency tactical response from about around the same timeline, which has been at the end of March, and that's included health. So I've brought in that health and social care tactical response into the multi-agency arrangement, and that's included colleagues from the local authority across the range of responsibilities that the local authority fulfil. It's included colleagues from police, fire and rescue, Department of Work and Pensions, Wakefield District Housing, Nova leading that third sector response, business sector, which has been really important through the Chamber of Commerce, college and prisons. So you've got a sense there of the range of organisations and systems that have been involved in that. And that, from my experience, has certainly been, that's reflected the already strong relationships we had across health and social care and the wider sector, and how actually in a very short space of time we were able to galvanise an effective response to the COVID-19 challenge. So in terms of that multi-agency tactical response, in the tackling it phase, the major focus, and a lot of that has been covered by Martin Barclay, was really to ensure that the health and social care system was set up to deal with that surge. So clearly a lot of that was about the acute sector and getting capacity. But to ensure that we're doing that needed a really strong response from colleagues in the local authority, in general practice, in community services, to support individuals at home, to ensure that we were actually able to discharge patients safely and find a safe space for those. We were able to actually release capacity so that 50% bed occupancy was achieved in a very short period of time, and that was as a result of a tremendous response to the system in terms of community care support, in terms of local authority support, packages of care in the home. We've mentioned the care sector, care home sector. I'll come back to that in a moment. So there was really a focus around that. There was also an ensuring, very importantly, that colleagues in primary care and community services also were able to respond in a different way. We set up what are known as red and green facilities within primary care so that we could stream patients with suspected COVID away from those with non-suspected COVID, so that the primary care could safely treat both sets. Significant changes in non-face-to-face activity with patients, both in a primary care setting and in an acute setting. The way that the community services and mental health services responded, as we've heard on the calls, most of those services were not stood down. We were able to maintain services but respond in a different way to those needs. So very much about the tackling phase was very much about a coordinated and mutual support. Much of that focus was around some of the challenges in the early days around PPE, the advice that we could rapidly turn around to organisations in terms of the way that we actually safely treat patients, social distancing, etc. We established very early on in terms of, and that was a really good example of partnership working with our colleagues in Swift and also Locala and others around establishing a testing facility in Fieldhead. And that was a really great success, and that was a very good example of the way that organisations came together in the very early days to deal with the testing, some of the testing. So we were able to establish testing for staff very early on in this process, particularly those key staff who needed that testing. And that was another good example of that mutual support. One of the key issues that emerged from all of that really was beginning to identify those individuals at greater risk and vulnerability because of the COVID experience, either as those individuals who had a greater risk of the virus and the impact it had on their health, but also the impact of carers who could no longer provide that support. For example, patients with mental health or learning disabilities problems who were receiving domiciliary care at home, the challenges of ensuring that they had the correct PPE and were able to provide a safe environment for those patients. The ability to actually support vulnerable individuals at home, the need to monitor vulnerable children and adults in this environment, where the challenges of children no longer being able to go to school, the challenges on their parents and others, and the wider issues around vulnerability that emerged because of COVID. And we've already heard in some of the early discussion the excellent response that the third sector through Nova, working with local authority through the 15 hubs, were able to support very practical support. Over 6,400 parcels provided to individuals since May. The ability to support, to give practical advice and support during that early days has been really tremendous. And the coming together, examples in multi-agency, colleagues in fire and rescue actually using some of their capacity to support a delivery of community pharmacy where patients actually couldn't get to the pharmacy. A wide range of very practical early responses, and that ability to bring together a range of agencies to work out of their normal areas and to come together to meet those vulnerable patients with the greatest risk. And that theme of vulnerability has been one of the key areas of focus, both in the health and social care space and in the multi-agency space. We've developed a lot of work around risk stratification, identifying those at greatest risk, and we're taking a lot of that data through a really excellent intelligence cell that's been supported through the local authority to identify on a day-to-day basis those individuals that are at greater risk because of COVID, and how we'll support them. So a tremendous response in that tackling it phase in terms of the early pressures on COVID. We are moving into, as Martin suggested, the living with it effectively phase. And obviously some of the key issues now around test and trace, being able to use the data now to actually provide more focused response to individuals. We're using that database around vulnerability to understand where we can focus our attention and support with children, with young people, with the elderly. So not only in terms of practical support, but a good example of that is really the patients who are shielded. Over 12,000 of them have been in Wakefield, and we've been able to galvanise practical support through primary care data, through the data that's been collected through people like Anthony Sadler and their areas, to actually, moving forward, to identify those at greatest risk. We're doing a mapping exercise at the moment to identify 3 areas of risk: clinical risk, economic risk, and social risk. And the reason we're doing that is to differentiate between those individuals who would require the sort of standard provision, but those, because of the complex nature of their needs, where we need to galvanise multi-agency support to focus on individual families or individuals. But what we're wanting to do as well is not create a dependency upon the system. We want to enable people to become as independent as they possibly can through this living with it phase of the process. But we do recognise that we need to ensure that there aren't any gaps in service provision. So this mapping exercise will enable us as agencies to actually identify those at greatest risk, review what we've already got in place, which is quite significant, but also to understand where we may need to actually bring in different models of care and service provision as we move forward with the greatest vulnerability within Wakefield. And that's been the key focus that we're now moving in terms of reset and stabilisation. One of the areas of attention, as well as the focus on the vulnerable, has been workforce support. We established a workforce cell in the Health and Social Care Tactical, led by Linda Harris, which moves across all agencies. And that's really been some very practical support and advice. We established a website for training and development that could be done through a non-face-to-face process. We provided a lot of support for the care home sector. We were able to galvanise very quickly a virtual support team of nurses who could advise care home managers and care home staff in terms of utilising PPE safely and provide advice, very practical advice to staff. Obviously, we are very much aware, and Martin's again described this, of the tremendous pressure that staff have been under and how that's affecting their mental health. And again, we've put a number of support mechanisms. I'd like to thank Sean, Rayner and his team and the other wider mental health for providing some very practical training and support mechanisms for staff who are clearly being under tremendous pressure during this time. So that theme is very much about providing support for the most vulnerable, but also for our staff across the range of services that we've provided. We're now moving in that tactical space into, as Martin's described, we're in that sort of space at the moment of trying to support the NHS in opening up services, but recognising that the new world and the new normal will not be in operating in the level of capacity that we were pre-COVID, because of the reasons that Martin's provided around the need for social distancing, the need for PPE, the need for all of the issues that we've got moving forward. And we're now mapping out across Wakefield, across the wider system, across the West Yorkshire and Harrogate, what that new normal will look like in terms of capacity, what we need.
For that, everyone. Okay, can I hand straight back over to you, Sarah?
Yes, of course. Can you hear me okay?
Yes, that's lovely, thank you.
Excellent, thank you. So I'll go back, I'll just go back a couple of sentences just in case. I don't know when the
when we cut out. But just to give a summary, Pippa and I are here today to give an overview of the health inequalities work at West Yorkshire and Harrogate. I'm just going to give a quick overview first of the wider programme, just in case people aren't aware and where this work fits. And then Pippa's going to cover a health inequalities pack that we're working up, which hopefully will be of some support to Wakefield, and it'd be great to get some feedback on how we can sort of link in better and how this resource can help. So in terms of the Improving Population Health Programme, the aims of the programme are really what the title of the programme around improving health outcomes and wellbeing for the population of West Yorkshire and Harrogate, and within that a real focus on prevention, on reducing inequalities, and on considering the determinants of health as well. So within that we've got the programme split into a few specific parts, so we can have a real focus on those elements. So we've got a prevention work stream and a prevention network. Within that sits the diabetes prevention programme, but we also look at a system approach to smoking cessation and reducing alcohol intake, etc. We've got a population health management network, and we've done some great joint working so far with the primary care networks, and Wakefield have been part of that as well. We've got the health inequalities network, which I'll touch on shortly. And then we've got what I'll call our kind of determinants of health part of the programme. And under that, we've picked out 3 areas that we think are really important in terms of improving health outcomes. So we've got a link into the West Yorkshire Violence Reduction Unit, and a member of our team works with the Violence Reduction Unit. We've got a Health and Housing Network, which was recently launched, and Sarah Roxby from Wakefield District Housing, she joins us 1 day a week to lead on that work, and having an initial focus on how we can support rough sleepers to access secondary mental health services, because that's come out as a real gap in the system. So we're looking at what we can do as a system to support that, and then that work's going to broaden out in general to look at how we can sort of improve standards of housing to improve health. We've then got a climate change network, which will be forming shortly, and we've just appointed 2 climate change leads, and that's really looking at what's the role in health in terms of reducing the impact on the climate, but also how can we improve things such as air quality to reduce health inequalities. So that's a real sort of broad overview of the programme as a whole. We've got a programme board that brings all those diverse elements together. And that's chaired by Robin Tuddenham, who's the Chief Executive of Calderdale Council, and James Thomas, who's the Clinical Chair of Bradford District and Craven CCGs. And we have membership from each of the places on that board as well. So Anna Hartley sits on it from Wakefield. We've got all the Directors of Public Health on it. So that's a bit about our programme and our sort of structure. And then we're focusing on the Health Inequalities network and the role of that group today. So that network is formed from representatives from each places, either in public health teams or clinical commissioning groups for working on reducing inequalities. We've also got representation from Public Health England, voluntary and community sector colleagues, again the Violence Reduction Unit as well. And the role of the Health Inequalities Network is to kind of consider what we can do as a system to take an approach together to reduce inequalities. So part of that is sharing good practice that happens in each place. Part of it is reviewing and scanning for national evidence and good practice and sharing that across West Yorkshire and Harrogate. And part of it is looking at what are the priority population groups and the real kind of wicked issues we'd like to tackle once, and how can we kind of work collectively on that as a partnership. So we've got some funding, transformation funding for our programme, and we've put a large proportion of that funding into reducing health inequalities and into the Health Inequalities Network. So this year we've aligned £100,000 to support improvement in outcomes for rough sleepers, and that links to the health and housing work I touched on earlier. We've aligned £100,000 to support improved outcomes for young carers, so we'll be looking to draw on a lot of the learning from Wakefield on that, because I know there's some great work that's happened in Wakefield already. And we've aligned £50,000 to improve outcomes for people affected by violent crime, with a particular focus on women and children. And we've also, I don't know if you've seen it in the media this week, we've just awarded, we increased the pot actually, we've just awarded £503,000 to our voluntary and community sector organisations across West Yorkshire and Harrogate, and there were 2 in Wakefield that have been successful. And the aim of that award was to reduce health inequalities through improving partnerships between health and the voluntary community sector, and we're focusing on those disproportionately affected by COVID-19. So we've got 13 successful applicants that were awarded that funding, and what we will do is kind of we're going to build on the learning and share it across West Yorkshire and Harrogate. So there are different places obviously have been successful, but also different population groups, so hopefully some of the learning will be transferable. So for example, some were focusing on mental health, learning disability and autism, some focusing on refugees and asylum seekers, some on gypsy traveller populations, and some on our Black, Asian and minority ethnic population groups. So I'm hoping there'll be some really good learning we can share. And to say as well, and I think it's been mentioned before, is that these inequalities sort of existed prior to COVID-19, and the response really has kind of shone a light on and potentially exacerbated inequalities, both in terms of the direct impact of COVID-19 and
Wakefield. 2 key parts of this presentation. So firstly, I'm going to give an overview of what we know at a national and regional level about how COVID-19 has had an impact on health inequalities. And secondly, introduce you to the health inequalities prevention pathway framework that we've developed and how it can be used to break down big issues, big ambitions into better understanding of needs and targeted interventions to reduce health inequalities. So hopefully you can see my screen, but I'll describe the slides as I go through in case there's anyone who can't see them. So the pack is an interactive PDF. It has a set of tabs across the top that you can use to navigate around the pack, and it has buttons that you can use to go backwards and forwards on the slides, back to the home page and back to the contents page. If I start with the introduction. So the introduction part of the pack tells you a lot of the information that Sarah's just taken us through. So it gives us a bit of an overview of the background, why the pack's been put together, to help provide a structured approach to understanding and mitigating against the direct and indirect impact of COVID-19 on health inequalities. It tells you a little bit about health inequalities in West Yorkshire and Harrogate. The fact that West Yorkshire and Harrogate, on average, we have a shorter average life expectancy than the rest of England, and that we have large differences between the most deprived and least deprived areas in the region. It tells you about West Yorkshire and Harrogate's 10 big ambitions, the first 2 of which have a big health inequality focus. So the first ambition is that we'll increase the years of life that people live in good health across West Yorkshire and Harrogate compared to the rest of England, and reduce the gap in life expectancy between people living in the most deprived and least deprived areas. And the second big ambition focuses on reducing the gap in life expectancy between people with mental ill health, learning disabilities and autism and the rest of the population. It tells you a little bit about the structure of the Improving Population Health Programme and the Health Inequalities Network, which Sarah's already described. And a bit of background about the framework that we've pulled together. It's really a tool that can be used to inform local population level planning to reduce health inequalities, and they could be ongoing health inequalities or new emerging inequalities that we know have come about in the context of COVID-19. So into the second section. The second section really takes us through health inequalities and the impacts that COVID-19 has had both nationally and in our region. So we know that COVID-19 has had an impact both on existing health inequalities that have been amplified, but also new inequalities that have emerged during COVID and the response. We've summarised this into direct and indirect impacts. So the direct impacts are the impacts as a result of COVID infection and severe illness for particular population groups. And the indirect impacts are the impacts that happen as a result of the control measures. So they could, for example, include changes to education provision, social isolation and loneliness, changes to health-related behaviours, all of which are going to have impacts on health inequality. So we've summarised that in this simple diagram here, but in reality it's a lot more complex. We know that there have been multiple overlapping direct and indirect impacts as a result of COVID and the response on people's health and inequalities. These include, for example, changes to housing, safety, rough sleeping, overcrowding, digital exclusion, loneliness and isolation, financial security, food security, health behaviours, education and early years support, and how we can access health services. But having said that, it's also important to note that not all of the indirect impacts have been negative. There have also been some positive impacts. For example, there's some evidence of improvements in digital literacy during the COVID crisis, and also people have had more opportunities to be physically active in some situations. There have been changes to air quality, and there have also been positive steps taken to provide accommodation for rough sleep. We then provide an overview of the timing of these impacts. So we're aware that the direct impacts have happened in the short term. So these include COVID, ill health, mortality as a result of COVID. But we know that this will have a tail as people need rehabilitation services as a result of COVID infection. But as we start looking into the indirect impacts, we're looking into the second, third and fourth waves, which are going to take place over a longer period of time. So then moving on to who is most vulnerable to these direct and indirect impacts. Firstly, thinking about vulnerability to COVID itself, this pyramid represents the people who are most at risk of COVID infection and most at risk of serious outcomes or mortality. And we're very familiar with these groups. So at the top, we've got the shielded groups. So for example, people with organ transplants or specific cancers. Second, we've got clinically vulnerable groups, which would include people aged over 70, people with long-term health conditions. And then at the bottom of the pyramid, we've got groups who are at a greater risk of infection or of worse outcomes. So that could include, for example, people from BAME backgrounds or people living in deprived areas. The British Red Cross developed a very useful vulnerability index. If you haven't had a look at that, it's worth having a look at the maps that they've produced of the most vulnerable areas, including in Wakefield. But when we look at the indirect impacts of COVID, we get a slightly more complex picture. There are many, many groups across society who are at particular risk of economic, social or broader health impacts as a result of the control measures. So that includes people living in poverty or with precarious employment, people who have long-term health conditions or disabilities, for example, people with autism or learning disabilities, people with ongoing mental health issues, people with unpaid caring responsibilities. People with particular protected characteristics may be particularly vulnerable to the indirect impacts. So, for example, people who are from BAME backgrounds, people who are recent migrants or asylum seekers, pregnant women and new parents. And then finally, there's a set of other groups, for example, people who are homeless, people who live by themselves, particularly if they're older, lone parent families, digitally excluded people who are at greater risk. And of course, all of these categories overlap, and people who fit into multiple categories may be most vulnerable. So to take you through a few examples, we know from national literature and statistics that people living in the most deprived areas are far more likely to be diagnosed with COVID and also to suffer from severe outcomes and mortality. The same is true of people from BAME backgrounds. There's considerable evidence of large inequalities in COVID infection and mortality for people from BAME groups, and especially for people from Black or Black British backgrounds or Asian and Asian British backgrounds. We know that people with particular long-term health conditions are at particular risk. So, for example, diabetes and hypertension. And finally, there's evidence that people with learning disabilities and autism have been at greater risk of contracting COVID and dying as a result of COVID-19. So we include a number of further resources to find out more about these issues. Now I'll take us through the Health Inequalities Prevention Pathway framework that we've developed. So the framework is a targeted approach to identifying, understanding and intervening to reduce health inequalities. There are 3 steps in the framework. The first is identifying the inequality that you want to do some analysis for. So that includes the population segment and the key outcome of interest. The second stage is intelligence and insight, using the Health Inequalities Prevention Pathway tool. And then the third stage is intervention. So thinking about the first stage first, identification of inequality. In this stage, you identify population segments and key outcomes. So population segments could be defined by demographics, geography, diagnosis, for example. And so, for example, we could take people with severe mental illness as a population segment. And key outcomes could be particular outcomes that contribute most to the inequality or to the gap that we see. So, for example, on average, people with severe mental illness have over 3 times the cardiovascular disease mortality of the general population. We can break this down into the 3 questions that I discussed earlier, so primary prevention, secondary prevention and tertiary prevention, to understand where the inequalities are and where we could intervene. So, for example, people with severe mental illness are 3 times more likely to smoke than the general population, and when people do smoke, heavy addiction is more common. They also have reduced access to smoking cessation services. Obesity rates are higher and alcohol rates are higher. And this, together with insight work, can guide us towards opportunities for intervention. We can also use this approach to think about COVID-19 outcomes. So for people with severe mental illness, COVID-19 prevalence may have been higher because people with severe mental illness are more likely to live in deprived areas and may be more likely to be exposed to the virus in hospital settings. In terms of secondary prevention...
Can I just interrupt? Sorry, Pippa. Is it okay if I open up the questions shortly, because I'm just very mindful of time as well, thank you, because it is all very interesting and I could listen to it sort of all day, but I'm just mindful of time for the other presenters as well. So is that okay?
That's fine. I've just finished. So just to finish off with saying that the toolkit can be used just to help understand the health inequalities that we're seeing in the region, including in Wakefield, and understand targeted ways to intervene.
Thank you, Pippa. That's really good information. Thank you. Can I open it up to questions? If I can, Mel first, please.
Hi there. Thank you, Chair. I hope everyone can hear me. I just had a question for Sarah, really, about something she shared at the sort of start of her presentation. I wondered if the board would find it helpful, Sarah, to understand what services have been commissioned with the resources that you highlighted in Wakefield. There was 2 areas, wasn't there? And I just wondered if that would be helpful to give a bit of a Wakefield flavour of what we're doing.
Yeah, sure. So we've got the Health Inequalities grant funding. Was that the one you were referring to, Mel? The 2 bids that have been approved in Wakefield?
Yes, that's what I was referring to. Sorry, Sarah,
yes,
for not being very
excellent.
clear.
No, that's fine. So we'll get some more detail out on in the next couple of weeks with what we're going to ask from each successful bidder is a bit of a plan on the page. So we'll send those to each place. You'll have much more of an idea. But just to give a quick overview, we funded one voluntary community sector called Open Country, and they're doing some work with people living with mental health conditions, learning disability and autism, and that's around kind of improving access to physical activity outside. So that was one we funded, and the other one is the Leeds Gypsy Traveller Exchange, but they're actually focusing their efforts for the funding not in Leeds but in Wakefield and Bradford, and that's about working with gypsy and traveller sites in terms of reducing health inequalities. So that's a really quick overview, but what we'll do is we'll share these plans on the pages when we have them with each place in the next couple of weeks. So you'll have a bit more detail on what's happening. The other offer is we've said we're going back to all the applicants that were unsuccessful, because we had 81 applications in total and some were just really good quality. We just didn't have the budget to fund them all. So we've gone back to each of the unsuccessful applicants and asked if they're happy for us to share their applications with places, just in case there's any additional funding or if you wanted to engage with them in any other way. So I can do that through whatever route's most appropriate as well.
That's really helpful. Thank you, Sarah.
Jo, would you like to ask a question?
Yeah, thank you, Pippa and Sarah. Great presentation, and you learn something every time, don't you, when you see things like this? So it was really insightful. I mean, you've highlighted some of the population groups that have been more adversely affected as a result of COVID. I wonder if Anna, sorry to put you on the spot, Anna, because I heard Shane Mullen in our place-based assurance meeting yesterday talk about some work that we're doing in Wakefield to understand that in our communities. I wondered if it might be helpful to just describe what that process is and how this might relate to some of this incredible work that the team have done on this tool.
Yeah, I can answer that if you like, Faith.
Yes, please, Anna.
So I think that as part of our work with vulnerable groups, Kerry Murphy, we've appointed as the lead for that 2 days a week, is working through this tool with Shane and the team to see how we can apply it to our Wakefield population, and that's for our test and trace programme. So more broadly, it has been really useful actually, and I think this is where the West Yorkshire work is just so useful, because there are definitely some things you just need to do once, and I think the sort of work Pip has been able to put in with her expertise and with Sarah as well has just been incredibly useful to then, because at the moment there's no way local areas can kind of put in that much energy. We're just far too dealing with COVID still, and so really grateful for that. Thanks.
Thank you, Anna. Yeah, thank you so much, Pippa and Sarah. The recommendation following the presentation is that the Health and Wellbeing Board note the presentation and to discuss any actions to take forward as a board. Can I just say that I alluded at that I was going to ask Esther to do a summary as we moved through the agenda, but moving forward, and I'm very wary of time, Esther's going to do a written summary of any noted actions after the meeting, and obviously that will be in the minutes as well. So I hope that's okay with everybody. So moving on to agenda item 7C, the impact of COVID-19 on carers in Wakefield. It's been quite some time now since we've had an update on carers. It's previously sat under the Integrated Care Partnership, but I feel it's really important to come here today. We all know this is a portion of our society who do so much but can easily be forgotten. So we have Maria Green-Lynch from Public Health and Justine Bilton from Carers UK, who are going to take us through the presentation. Again, just remind everybody that I'll invite questions and comments at the end. And I'm really sorry to put pressure on Maria and Justine, but I am really mindful of time, and I have to say that we did cut Tom's standard quite short last time, so I want to ensure that we've got enough time for Tom as well. So thank you very much, ladies. Thank you.
Okay, are people able to see my desktop, my presentation?
Yes, that's really clear, thank you.
Oh, brilliant. Okay, I'll just start it from the beginning. Yeah, so you can see that, you can hear okay.
Yes, that's lovely.
Fabulous. So as Councillor Hepton-Stall mentioned, my name is Maria Green-Lynch and I work in public health as a carers champion, and I'm joined by my colleague Justin Dalton, who is Chief Officer at Carers Wakefield District, not Carers UK. So we've been asked to come along and just share some information about the impact of COVID on unpaid carers during the last few months. So I just wanted to start by sharing some information about the national picture relating to unpaid carers. In April 2020, Carers UK conducted a piece of research called Caring Behind Closed Doors, which looked at how carers are affected by the pandemic. And it highlighted that an estimated 4.5 million new people have been forced to take on caring responsibilities as a consequence of the pandemic, which is an enormous number, and that's equivalent to three times the size of the NHS workforce. So when we translate this figure into what it means in Wakefield, it potentially means that we've got an additional 23,000 plus new unpaid carers in our district. And given that in Wakefield we've got a slightly higher proportion of people who've been shielding, that 23,000 could be an underestimate. So when we add that to our 36,000 carers that have been identified through the 2011 census, which is also likely to be an underestimate, we're looking at an unpaid care population of over 6,000 people in Wakefield, which is enormous. So Caring Behind Closed Doors highlights that coronavirus is having a profound impact on unpaid carers. It tells us that the majority of new carers are likely to be women, and many of them are already living in poverty. Interestingly, it identifies that new carers are typically younger than unpaid carers usually are, and consequently they're likely to be juggling their caring responsibilities alongside their paid employment. And it also highlights that 100,000 people who are providing unpaid care have been forced to use food banks since the start of the pandemic. And yet, referrals to carers services locally, nationally and regionally have decreased. So it is absolutely the case that carers are caring behind closed doors without access to relevant support services. This slide, and I'll just quickly run through it because I know that we've pushed for time, but you can see that 70% of carers report that they're providing more care because of the pandemic, and on average that works out as an additional 10 hours per week. 35% say that they're providing more care because services have reduced, or they've switched to remote working, or they've closed. 69% of carers saying that they're having to give more emotional support to keep to check on the loved ones and keep them motivated and buoyant. And 81% report that the pandemic is having a financial impact on them, including spending more money on food, and 50% report an increase in household bills. 88% say that they're worried or extremely worried about their current financial situation. And as well as worrying about their loved ones becoming ill, as you can imagine, a huge number of carers, 87% of carers, are worried about what will happen to them if they become ill or have to isolate and they're not able to provide their usual care to their loved ones. So you can see that carers are affected emotionally, physically and financially. This slide just shows a breakdown of the types of care that carers are increasingly providing because of the pandemic. I've mentioned the emotional support, but they're also doing practical support, such as shopping, washing, cleaning, taking the person that they're there for exercise, arranging distance food deliveries, organising appointments and medication for their loved ones, providing personal cares, supporting with paperwork and financial matters, giving support to ensure that the cared for person takes the medication, and in some cases providing medication, like changing dressings or giving injections. So we know that being a carer was always tough, but right now it's tougher than ever for our unpaid carers, and Justine's going to tell you a little bit about our carers locally.
Hi everybody, it's Justine Bilton here from Carers Wakefield and District. Can you hear me okay, Councillor Stalk?
Yes, that's great, thank you.
Hi there. So I've not actually got access to the slides. Maria's going to hopefully just move on. We just wanted to give you a quick overview of the issues that we've come across as a service and just a small example of some of the issues that carers are experiencing. So it was really interesting to hear the previous slides, because across all of these groups that were mentioned, most of those individuals will require either a family or a friend to support them, and so that it actually supports the system. So it's even more important that our unpaid carers are fully supported to help them to continue to care and lessen the burden on the upstream services. It'll not come as a surprise to you that we're offering a service much like most other services like ourselves. So we very quickly went to remote working. We continue on, but not face to face at the moment, although that has slightly changed. We connected really quickly, very early on, with other third sector providers and the council's customer care contact centre to be able to get carers some support with things, the practical things like shopping and prescriptions, etc. Our carers that have a loved one in a care home, it'll not surprise you to learn that they've had a particularly tough time, mostly around sort of visiting really, and getting access to information about their loved ones. So very quickly we went to the community anchors who were able to provide some tablets or laptops that we were able to loan to some of the care homes or to carers so that they could keep in touch with their loved ones. Very early on, we started talking to carers about contingency planning. We've had over 300 discussions with individual carers about that. So, what happens if they become ill or the person they're caring for becomes ill, we formalise some of that. Worryingly, again, with the care home, particularly with carers with people in care homes, we've had lots of support to those carers around advanced care planning. So basically around sort of end of life treatment, etc. And ordinarily in a month we might see one of those discussions, but we're seeing more like 4 a week in the early days of the pandemic. Staff resilience has been a real issue. We've come across some really, really, really difficult conversations. And in actual fact, 3 of my staff were bereaved in the first month of the pandemic, which was, as you can imagine, really tricky. Presence has been around, like I say, remote working, lots and lots of telephone contact. Our support groups have been meeting virtually where they wanted, so we put carers in touch with other carers where they wanted to do that. But we are starting to change things a little bit. So we've started doing, we've introduced garden visits instead of home visits while the weather will allow. And in fact, I'd like to have a conversation with the council. We rent our property at King Street from the council, and we've got a small backyard that we might be able to convert, have a bit of a gazebo and a patio eat and some seating. So we'd be able to see carers outside there if that's what they require. Thanks, Maria.
Sorry, I'm not pushing you, Justine. Sorry.
You're all right. So we're still getting referrals at a vastly reduced rate. But I think, like everybody else, other services that would ordinarily referring to ours have been firefighting. So, they've been looking after their own business and probably not thinking, beyond that. But we are starting to see sort of small shoots of recovery. Like Maria said, that it's not just a local issue. It's really worrying that we're not able to identify new carers. We have been having a conversation with Pinderfields. We've got a couple of staff who did work in Pinderfields and supported carers within the hospital setting. So we started to have conversations about those staff returning to Pinderfields, and that conversation is happening as we speak. Thanks, Maria. So this slide just sort of gives you some of the examples that carers, some of the issues that they're coming across, some of the common themes. And as Maria said, they're having an extremely tough time, particularly in the early days. I think, as we all are, we sort of, we're starting to get used to this thing and start to live with the new norm. We had some really difficult conversations with carers within the first week of lockdown. They were being contacted by some clinicians and being told that their loved one may not be likely, that they wouldn't be actively treated should they catch the virus. That was particularly emotive, a time for us. We've had carers who moved in with their loved ones right at the beginning of the pandemic, and in actual fact, now we're starting to feel resentful of that decision. It's a really, it's a tough position to be in, and it's having an impact on their own health. So, that's a worrying situation. Again, with our care home carers, again, they, having some really tough conversations with those carers. So, for example, one elderly gentleman who was desperate to remove his wife from a care home, and of course it wasn't in the best interest for that to do. So he was actually threatening to take his own life. Lots of support with that particular gentleman. But we've been able to work with the care home manager and ensure that carers do have access, sort of face-to-face access with their loved ones. So that's been a positive as well. We've had some really, built up some really good relationships. We've helped carers with a lot of the practical stuff, the shopping, as I mentioned. Carers who are caring for people with mental health issues, again, has been particularly tricky. It's exacerbated some of their conditions, and also some of their loved ones have found it difficult to sort of stick to the lockdown rules as well. So that's been particularly tricky. Thanks, Maria. So, as Maria mentioned, we are struggling to get new referrals into the service. As you can see from this slide, the comparisons from the same period last year show a marked decrease in referrals. So what we've done is, we've continued to ensure that our usual referrers know that we're still around. We keep sending out, sort of mail shots and advertising and that type of thing. We have, lots of contacts, but with less individuals. And as you can see, the new referrals are down 60% from the same period last year, which is really worrying. So we took it upon ourselves to do a database sweep. So currently we've got around 8,000 carers who are captured on our database. So we did a sweep of that and made a list of carers that have contacted us within the last 12 months, but not during the pandemic. So we're starting to go, and there's around 1,500 carers on that list. So we're starting to, make us way through the list, making welfare calls, and actually it's surprising that, carers were surprised that we were still functioning, and hence the reason that we're not getting the contacts in, and we're really grateful with that. So, as I said before, we are regularly contacting our partners to remind them that we're still here. I absolutely appreciate that other services have got their own issues and are, sort of ensuring that their own businesses, their own backyards are sorted. We've done mail outs to GPs. Sadly, we've only had 2 responses from 2 GP practices. Posters and press releases in mid-Yorks about the service. Only 1 carer referred through that, but that's sort of understandable. We've only just started to get visitors back through into Pinderfields, and again, like I said, we are starting to discuss whether or not our staff go back into Pinderfields when it's safe to do so. But we are starting to see some small improvements on that. For example, last week, we sort of got 7 referrals in one day, which was quite unusual in this current climate. Not unusual before, but unusual at the minute. So, we just want to get the message out there that we're open for business. All staff are working. We've got some staff who aren't working particularly effectively due to the circumstances at home. But we're utilising all that we can, and we're here. I'll pass you back to Maria on that one. Thank you.
Okay, thanks, Justine. Just just wanted to mention that during Carers Week, where the theme was making caring visible, we held a partners meeting and invited lots of services that are working directly or indirectly with carers to come together and share what they're currently doing to support carers. And we looked at successes, challenges, and what next. As Justine and others have mentioned, successes were the way that services very quickly flexed to remote ways of working to ensure that the support is still available, and those telephone calls and switching to a virtual offer has been something that all of our services have done, so that carers can stay in contact with services, and also providing equipment to carers so that they can stay in contact with carers and services and also friends and family, has proved really successful. And as Justine mentioned, kind of finding ways for carers to stay in contact with those with their loved ones who are in hospitals or care homes has proved successful as well. Services have managed to maintain their emergency services and offered crisis management. We made sure that contracts were extended so that our services do continue to provide services for carers. We've supported the third sector through providing grants. And what has been really successful, as Justine and everybody else has mentioned, that partnership work in making sure that all services are linking together to support the district-wide response to COVID. Some of the challenges have included equipping staff with the resources to work from home, and some of the staff resilience and the difficulties that they might be personally facing. And not seeing service users face. I've recently appointed a new young carers early help practitioner. She joined us during the pandemic, which has been interesting. But we've put together a strong action plan for that piece of work, and we're working on a promise document which has been developed in partnership with young carers as a consequence of them attending the Children and Young People's Partnership Board. So we're looking at producing a young carer strategy co-produced with young carers, developing some relatable branding. We've got surveys that have been out to schools to help schools to think about their young carer population. Do they know them? What support might they need to increase their young carer awareness and consequently identification and support available to young carers in schools? And that will inform us to develop some training that is appropriate for those professionals. And also we've got a suite of newsletters which will be produced for young carers, families and professionals. So we want to increase the numbers of known young carers as well as the offer that's available to them. Just some of this is the last slide, I promise. Some of the things that young carers are highlighting. So our youth work team have been making welfare calls to young carers. They've highlighted that young carers are saying that they've got increased care responsibilities. They're missing the respite that school provides. It's had an impact on their emotional health. Some young carers are struggling with the lack of routine. They're worried about their loved ones becoming ill. We've had one young carer who lived with mum, single parent family, who lost mum during this time and has got no other family members. So, you know, some of our young carers have been particularly affected by this pandemic, and there's been a multi-agency approach to supporting that young carer and other young carers as well to ensure that they do have access to support. And also we're signposting young carers to virtual support, such as the COOS website and the new website that's been developed at WFI Can, where we're specifically trying to target young carers and promote that resource to them. I think we're about finished. Welcome any questions if anybody's got anything that they'd like to ask.
Thank you, Maria and Justine. Can I open it up to questions? If anybody's got any questions they want to indicate in the message box. I note the comment from yourself, Beate, yeah, that there's lots of work going on with young carers, including the virtual groups. Thank you. Do we have any further questions or comments? Jo?
Yeah, thank you for that, and hope you're both well. Not seen you both for a long time, so it's nice to say hello to people, isn't it, when we've not seen them both for a long time. I know that you're doing some incredible work, and I'm just picking up the point around the primary care referrals, and I'm just wondering whether, as an action, Mel, you might take back to one of our primary care network meetings. There's a meeting next Thursday actually, even though we're probably not, we're obviously not seeing people face to face, but we are in contact with a lot of people through primary care, and it is getting busier. So I wonder whether we could just look at ways in which we could make those connections where they need to. I know our primary care team have been doing some incredible work around shielded patients, and really proactively referring to some of our social prescribing interventions across the district. So I think it's just about joining the dots.
Yeah, happy to do that with Justine, Jo, so I'll pick that up. Thank you.
Yes, thank you. I'm just noting the other comments there. So yeah, that's great. So thank you both, Justine and Maria. And as everyone knows, this is something I'm really, really passionate about. So thank you for all the work that you're doing across all our communities. Thank you. So can we note the presentation and take forward the actions that's already highlighted, which I'm sure Esther's making note of. Thank you. So that takes us on to agenda item 7D, Tackling Inequalities through Employment. This discussion was started back in January when Tom came to talk to the board, but unfortunately back then time was not on our side. If members recall, we said that we would bring it back to a future meeting for discussion. Given the current economy and the importance of employment and health and wellbeing, it feels like it's the right conversation for the board to be having as to how we can support our communities into having greater wellbeing through employment. Tom and Linda Harris will be talking through the presentation, and I know they posed several questions at the end. But if I can hand over to Tom and Linda, thank you.
Thank you, Chair, and grateful for a bit of time on the agenda on this today. I suppose what we had planned as the follow-up to this when we spoke about it in January is obviously changed in the conditions of the crisis and the pandemic for reasons that, you know, I won't rehearse because I think other speakers have more than done them justice, quite honestly. Linda and I have had a number of conversations with Jo and other colleagues outside the meeting, following on from the January discussion, but particularly in the context of the current pandemic. Linda is very kindly led on development of the paper that went out with the Supplementary Agenda, and I think she was going to speak first to just talk us through that, because I think the big opportunity Linda and I are keen to talk about, as well as the broader employment and skills benefits of us continuing this conversation about collaboration with Health and Wellbeing Board, is really where the Council's Step Up programme and the workforce programmes under the board and the CCG could potentially meet in quite an important opportunity, I think, for tackling unemployment risk, but also simultaneously trying to bring some benefit from that to the workforce strategy across the whole system, really. So I'll perhaps hand over to Linda to introduce that, and I can say a few words at the end, as well as you say, Chair, pointing the board to commenting on the bullet points in the end of our report, if that's okay.
Thanks very much, Tom, and thank you again, Chair. Just following on from Tom's really helpful introduction, and great to be working with Tom on this. It's very much an opportunity for me as SRO for Workforce for the Wakefield Integrated Care Partnership. You can hear me, by the way, all right? Yep.
Yes.
Yes, thank you.
Oh, yeah, great to have as SRO for Workforce for the Wakefield Integrated Care Partnership to co-present this discussion paper, which we've co-authored, which I think is a real opportunity to look forward how we might seek to tackle inequalities in health through employment, and in so doing, specifically explore what I think it's fair to say, I think we both believe are significant synergies and good timing between the workforce development and planning in the health and social care sector nationally, locally, and the fantastic Wakefield Council Step Up programme, which I know Tom will go into in a lot more detail and better able to describe than I. So what I'd like to do is just try and provide some background context, and then I'll hand over. As previously alluded to in the presentations from Joe Webster, Martin Barclay, Pat Keane and our public health consultant colleagues, COVID has shone a really significant light on that relationship between inequalities in health and well-being and life chances. And of course we are now very much as a system learning about what we want to adopt, what we want to amplify, what new ways of working there are for us all to reflect and take forward. And the opportunities presented to us as a system to bridge gaps in health literacy and the link between that and the wider collective economic regeneration goals. It is absolutely a golden opportunity to be seized. And one of the things I think in the discussions we've had in preparing for this paper that we'd really like to get out of today is to open up the discussion and think about how best we can target some of our collective resources so that we can assist many more people to consider health and social care as a fulfilling and a sustainable career for themselves and their families. And then in addition to this, and again promulgated by COVID-19, there's been some real, and it's brilliant, isn't it, some positive light shone on the health and social care sector in hosting the roles and jobs that are so responsible, so compassionate, and such challenging and critical positions. So just in terms of the sort of the synergy and what is the opportunity, the Wakeful Workforce Programme Management Office, which was established and I was given the opportunity to lead initially through the Vanguard and now aligned with the Wakefield ICP priorities. Over the COVID-19 period, we've been focusing our efforts on collective resource planning and we've been strengthening that governance infrastructure and the networks across the system. And my thanks to Pat in his presentation earlier for providing the board with some of the notable achievements of the PMO, working with the system, whether that's through the strategic and tactical command support work we've done, the development of our hub website, the memorandum of understanding for staff redeployment, and the excellent opportunities we've had to work to support the care home sector. And we've learned, but I think we've also strengthened and improved an understanding of the responsibility of the PMO in taking that forward. And what I think now I'd like to suggest, for members to engage with is this relationship with the Wakefield Workforce PMO and the Council in how we might take a strategy forward to provide the district's residents with an improvement in their employment status, prospects and progression through the health and social care sector. Now, we already have in the work that as SRO we're leading in Workforce PMO, overseeing a number of associated projects which I think align well. So whether that's the placement of Huddersfield University students into the independent care sector in Wakefield and North Kirklees, and also the emerging really exciting project that the ICS affords us as an opportunity in Wakefield around trainee nurse associates. So within the paper, there is a flavour of some of the Workforce PMO agenda, and I said where we are poised, I think, through this opportunity for joint planning and execution to align ourselves with some of the Step Up programme objectives and aims. And I hope I've done that sufficient justice, Tom, to segue into your more in-depth introduction into the Step Up programme. So I'll pause at that point and hand over, if I may.
Yeah, thanks, Linda, for the cue there. Yeah, that's very helpful. And Chair, I have, as well as the information in the report we've done jointly, you'll see appended to that an example of one of the regular progress report updates that we do on the Step Up programme itself at the Council. I've got some presentation slides, but given the time, I won't try and grapple with projecting them to you, but happy to circulate those afterwards, which just give a bit more of an in-depth account of the programme and the operating model that Linda's alluded to. I think probably the most important thing, which is linking back to the discussion we had in January, though, is making sure that when you look at the current crisis, recession risk, and particularly the employment and labour market impacts of that, I think what's still striking about all of that is that government programmes and government intervention initiatives, particularly including the 16 to 25 job creation and job retention scheme that was announced by the Chancellor earlier this week, still focus importantly on young people and new entrants to the labour market for the first time. And important though those cohorts are, there is still, in our view, and particularly because of the particular economics and labour market dynamics of the West Yorkshire region, a really important issue to continue to focus on the needs of adults who are over the age of 25, living longer working lives, making multiple career transitions throughout those lives, and who are, we know from all of the redundancy impacts and company collapse impacts, as well as the hidden redundancy impact that's likely to hit when the furlough scheme comes to an end, facing a particular economic continuing employment and future unemployment dilemma within Wakefield, particularly in our most deprived communities, as well as across the wider West Yorkshire sub-region. And I think it's important to say that in relation to the kind of proposed expansion of this programme that Linda referred to, we are also in the process of proposing a similar kind of replication and expansion of this as an all ages skills strategy as part of the regional recovery planning as well. So I think the main issue and agenda here is creating an infrastructure that has been, being quite candid about it, quite badly damaged by the last decade or so of austerity, creating an infrastructure that enables us to intervene with that cohort, to enable adults to reskill, to change careers midlife, to skill up and be eligible for progression within their current sector of employment, but also progression within and between other sectors. And that's where we think the key agenda for this board comes in, because there is an opportunity with greater levels of unemployment, greater levels of economic distress and greater levels of job risk for us to try and meet those two agendas as an opportunity. In other words, to put some specific capacity into the Step Up programme to help, on the one hand, deal with that greater level of risk in the working age population across Wakefield district, but on the other hand, to benefit what we know are the, very well-known health and social care sector workforce expansion issues and workforce pressures that Linda's programme has been working on effectively over the last few years. So I think that's probably enough in terms of preamble. We've posed the questions which are set out on it's agenda page 4 of the supplementary paper, Chair, that came around. There's some bullet points at the end there. And offline, really, and not kind of described in detail at this paper, in the paper at this stage deliberately, Linda and I have also been having a discussion about pulling together a business case for a jointly funded post that could sit within the, effectively sit across the Connecting Care programme, the workforce programme within that, and the Step Up service, to focus specifically on upskilling, retraining and recruitment issues, but specifically focused on the various multiple professions within the health and social care workforce. I think the final thing I would say is this is about rebuilding. This is the crucial point with this, really. It is about rebuilding and enhancing the brokerage infrastructure that helps individuals navigate a very, continuing, very complex employment and skills and retraining system. It's not at this stage about providing the additional funding for paying for retraining, for funding providers to undertake retraining for adults in these positions. But we do know, on the one hand, there is a colossal underfunding on that side that we've got to grapple with and that we are lobbying about. But equally, there is also a growing opportunity for us to have greater, at least regional determination of how that funding for training is allocated, particularly but not exclusively through the devolution of the adult education budget under the West Yorkshire devolution deal, which was agreed at the start of this year. So I think this is about us innovating to create and improve the brokerage system across our local health and social care system to support a vulnerable cohort of adults who are either redundant now or at high risk of redundancy, to retrain and be re-employed in other sectors, but also to upskill and have prospects for career progression and therefore higher levels of earnings and improve family well-being in and around that sector. And I think hopefully with the board's support and backing, really, Linda and I can do some more work on the business case around capacity for this. And I think from the council side, and I know from Linda's perspective, there would very much be a commitment for us to do everything we can to fund that capacity on a partnership basis with contributions from the council side. What we've found as the final point, Chair, is that the Step Up programme is the type of programme that with relatively low revenue costs for the brokerage service can deliver quite significant employment and skills support outcomes for the local community. Since we launched it in the late summer last year in 2019, we've already enrolled over 400 clients onto the programme, so working with quite a large client base already, and put in place significant support for all of those people for job brokerage, retraining, upskilling and improving their prospects in the rapidly changing work and career markets that we know about. So I'll stop there, but I'll just point the board to the bullet points on page 4, and hopefully we can have some input and comment on those, and obviously very happy to speak to people outside the meeting as well, and with your blessing and colleagues around the table, the virtual table today, Linda and I will try to continue and enhance the partnership working around the business case for some specific investment for the health and social care workforce cohort in this programme. Thank you.
Thank you, Tom and Linda. You've definitely given us lots to think about. Pose questions to the board, but does anyone have any questions for Tom and Linda to help us address these questions?
And Chair, apologies, I saw as I was speaking that the magic wand from somebody else made my slides appear, so apologies, I was possibly talking out of order of what was on the slides, but hopefully they were helpful to illustrate some of the points I was making as well.
Chair, whilst people are pulling their thoughts together, and thank you, Tom. I mean, I think you really have captured, I think, the energy that we have to take this forward with the board's blessing. But I just wanted to reiterate that we are in a good position. The workforce PMO has already started drawing on its HRD network. So the network of workforce specialists and HR directors across the system have already started a piece of work around recruitment and talent management, and there's a task and finish group there which can also feed into this. And I just wanted to highlight the ongoing work on adult social care recruitment, which had started prior to COVID and is now being picked up again by the Care Home Workstream Group, which the PMO is supporting with Alison Critchell and with Skills for Care, and we're doing a piece of mapping work with the stakeholders involved in that. So I think in terms of taking a case forward, that this is really the opportunity to have sort of a health and social care specialist, as you say, to bridge that gap between the two programmes. But the good news is both programmes, I think, are in a good place to sort of catapult and build on taking this forward because of the existing work that's in place.
Thank you, Linda. Can I bring in Jo?
Yeah, thank you, Tom, Linda. Great presentation, very strategic, and a really good opportunity. So I really support that. I just wanted to say that I would actually support the concept of having the health and social care specialist as you've just described it, make the link so that we can take opportunity for the concept of the Step Up programme as Tom has outlined. And I think that we were always on the journey of looking at new roles in Wakefield as part of our integration journey, that not everything has to be about a medical intervention, and not everything, more about social, etc. And that actually, in order to raise sort of the ambitions of local people, that we do need to support them. And I know that's what the fundamental sort of aspirations are around the Step Up programme. We've actually had some success, Tom, with this kind of approach around the learning disability, vulnerable groups, and we've had some trainee schemes. And I'm just wondering whether or not there's I know Martin's had to leave today, but I'm sure he'd be very interested in having a separate conversation with you and myself, Linda, whoever, about how we might just create what are the skills that you'd need to enter into the health system, both now and in the future. Because the one thing that we are very short on in the health system is workforce. And we do need to try and encourage people to want to come and work with us, and it's a great opportunity, isn't it? Because at the moment, everybody feels really sort of grateful, proud, and thankful for the NHS, and wants to give something back, and that's being shown by all the volunteers that we've had, and some of those, as you say, unpaid carers and people like that are really valuable to the system, actually, because the NHS wouldn't be available, wouldn't be able to do what it does without them. So we need to take a couple of conversations out of this meeting with those organisations, and then maybe have a conversation at the Integrated Care Partnership where all the organisations are there across health and social care, and have more access. I know that probably cuts across, Linda, the workforce group, but I think what we ought to do is get it sponsored by the chief execs around that table, so then that would make it more relevant to the workforce group as well, and be part of our strategy really around recovery. So that's what I would say, but I would support the specialist. So
no, I'm happy to come back on that, Jo. I completely agree. And I think whilst you were speaking, Jo, I think it's so easy as well for us to think of the health and social care sort of workforce sector in term, and particularly over COVID, in terms of doctors and nurses and therapists. And of course, it's a vast array of different roles, responsibilities across administration, corporate, research. There's a whole host of things, and I think it's how we market the whole sector in its broadest sense. Which gives a sort of wealth of opportunity, but I would really value that additional sponsorship from those executive leads.
Thank you, Linda. Andrew, you have a question?
Yes, if I may. Thank you both for the presentation. It was really helpful, and for the reports as well. I guess the bit that I thought was kind of particularly important is that concept of a career progression, and people perhaps who start in domiciliary care or in the more low-paid areas of caring who have aspirations perhaps to develop their career, and there not being very many options at the moment. So I think getting your reflections on whether we've got the right people around the table or the right organisations to help creatively design some new pathways. And my second point was really, excuse me, about connections to the previous presentation, that amongst unpaid carers, particularly for younger carers whose education's often impacted by their caring responsibilities as well as other things, but as an unpaid carer, people developing the skills and the understanding that's required to enter into more formal caring occupations. It's perhaps not right for everybody, but for those who are carers, particularly if we're seeing more unemployment amongst unpaid carers, whether we can connect the two and open up career opportunities for unpaid carers into the paid sector.
Mm-hmm. Yeah, I mean, I think if I may, Linda, just briefly on that, I think that, you know, both points on my radar as well, Andrew, and I think really well made. We have actually got a health and social care pathway identified as a priority in partnership work across our services and the whole learning and skills partnership for Wakefield in the economic strategy. But I think really there is an opportunity to kind of dust that off and refresh that work because of the kind of rather curious opportunity we've now got with the zeitgeist of the pandemic, alongside the unemployment risk, alongside the kind of newfound, I think, public celebration really of regard for the caring profession. So I think we do need to do that, and I think we need a better bit of intelligence to support that work. That is partly what the capacity in our teams at the moment and the new partnership capacity Linda and I have been discussing would provide, that helps to really bring in intelligence about the opportunity for those pathways, particularly across the various learning and skill providers across Wakefield and the region, not least our own college and the HEIs, who've got, I think, pretty strong health and care pathways in a range of institutions across the region. So I definitely support that, and equally I think the the challenge really with the unpaid carers issue is that clearly for a whole host of reasons it's not suitable for everyone, and the transition into paid employment is not possible for everyone who's in an unpaid caring position, because they're balancing all those different family, loved ones, demands and other issues in their lives. But I think the sands on that will be shifting because of the scale of the economic impact of the last 3 or 4 months, which is going to cast a long shadow really, as we all know. So I do think there's opportunity to connect these two programs to work specifically with that cohort, and I think that's, as I say, good advice, points well made, that we take that into account in the development of the program over the months ahead.
Yeah, the only thing I would add to that, Tom, if I add anything, is just being minded, and Joe will know that is the opportunity with any this being an innovation to ensure, and I can do this through my role on the People Board, the ICS Education People Board, to sort of raise awareness of the points you quite rightly make, Andrew, about how the People Board as well, and the initiatives that come through the ICS can support what this is all about, what this joint project is all about. I also sort of take your point about have we got the right people, around the table engaging and supporting this. And I think again, there's an opportunity there to either create a greater emphasis for certain, whether it's HEIs or the learning sector. And I think I've got some learning as well in that respect. Yeah, that's all I would add there.
Okay, thank you, everybody. I think that discussion sort of weaved through your questions, and I hope that has been helpful. Does anybody else want to ask any other questions or make any more comments at the moment? Thank you, Mel, for your comment. Really excellent topic. Thank you. Oh, I'm just noting that Linda is typing a message.
Chair, could I just add? Yeah, well, Linda's just said it really. Thanks for a bit more time to discuss this. I know there'll be a lot of people who have got strong views and opinions and a lot to add to this programme. So, you know, and I know Linda will be well connected with lots of you, as I will be with colleagues on my side. But very happy to have conversations following on from the board meeting to pick some of this up and make sure that we are, as far as we can, involving the whole system in the design of what we do with the next steps on this, which I think is really part of the point that Andrew is making about the learning and skills system and how we connect with unpaid carers and more besides. So that would be great if we can pick that up outside the meeting, and happy to talk to people one-to-one or three-way with Linda. But thanks for the opportunity to talk about it again today.
And likewise, Chair, thank you.
Yeah, no, thank you both, Tom and Linda. And as I said earlier, I think you've given us lots to think about, which I've really welcomed the discussion, and I'm sure we'll pick it up quite a lot outside of the meeting as well. So thank you. Okay, that brings to item 8, Connecting Care Executive Minutes, which is just for information, unless Mel, you wanted to make any quick comment on them.
I haven't got anything to comment about those minutes, Faith, but we have had another meeting this morning, so we'll make sure that they're obviously shared for the next meeting as well, but nothing further to add, Faith.
Thank you, Mel. And item 9, do we have any other business? No? So moving on to item 10, the date and time of the next meeting. This is to be agreed, and we will notify members as soon as possible. So I'd just like to finish by saying thank you to everybody for attending this afternoon, and thank you all for your patience and for your presentations. And with that,